who has made powerful contributions to the field of neurosciences. She is going to deal with the session about future implications for ADRD. We welcome you, ma'am.
Thank you, Divya, for the kind introduction. Good morning, everybody. I'll be talking on the topic future implication of COVID-19 for Alzheimer's disease and related disorders. The basis of this will be how COVID-19 impacts the brain and followed by the implication in ADRD. So the outline of the talk will be neurobiology of COVID-19, which includes neurotropic coronavirus, neuroinvasion, neurological manifestation, neuropathophysiology, and followed by impact on ADRD. Historically, many virus strains some virus strains of corona are known to be neuroinvasive and lead to neurological complications in subgroup of patients with corona infections. And these coronavirus, if you look at them, they are enveloped RNA virus and they fall into 3 genera. They can be alpha, beta, or gamma coronavirus, and they are known to infect human and numerous animal species. Currently, there are about 7 coronavirus, and the beta coronavirus of these are known to cause severe disease in the humans, and the 3 that are already known to cause infection in humans belong to this group: the Sars Cov1, COVID-2, the present coronavirus, and the MERS-CoV. And most of these human coronavirus are typically known to cause respiratory tract infection, and only 3 of them are known to cause known to infect the neurons. Now, starting with the SARS-CoV-1, this has known to cause in 2002 an epidemic of severe acute respiratory syndrome, and also in addition, it has caused neurological conditions like encephalopathy, seizures, stroke, cranial nerve palsies, peripheral neuropathy, and myopathy, and the mortality associated with this was 10%. MERS, that is Middle East respiratory syndrome. The virus causing this involves multiple organs, including the brain, nerves, and muscles. And this pandemic occurred in 2012 in the Middle East. The novel coronavirus, which has led to the COVID-19, emerged in late 2019 in Wuhan and was traced to the market in Wuhan in China. And this advanced globally to cause a pandemic, which was declared on March 11, 2020. And of the latest counts, we have as on 21st, there are about 30 million confirmed cases and 9 lakh deaths resulting this virus. Now, COVID-19 is the name to the clinical syndrome caused by this SARS-CoV-2, and it was initially known to be a severe respiratory syndrome, but later it came to be known that it can involve multiple organs, including the CNS. And the initially data shows that among the 214 COVID-19 patients in China, 36% of the symptoms was related to the neurological manifestations. Now, SARS-CoV-2 has got high similarity to SARS-CoV-1, and both the virus bind to the cell in the humans using the angiotensin converting enzyme receptor 2. And once it binds to the receptor, it uses a serine protease to prime the spike. Now, the AC2 receptor is uh, present in number of cells you get in the human you get organs. The binding of this binding to this receptor is a critical step in the pathophysiology of clinical manifestation in patients with COVID. The function of AC2 in normal human is to regulate the blood pressure via inhibition of angiotensin renin aldosterone pathways. Now, the AC2 normally what it does is facilitates the conversion of angiotensin 2 to angiotensin 1. And the higher level of this has been associated with vasoconstriction, renal failure, heart disease, apoptosis, oxidative process that accelerate aging and promote brain degeneration. Now, the viral cellular tropism is determined by where all this AC2 receptor is present in the tissues. It is expressed in the airway, epithelium, kidney cells, small intestine, lung parenchyma, vascular endothelium throughout the body and widely throughout the CNS. The widespread expression of AC2 in the brain tissue raises a concern that SARS-CoV-2, similar to SARS-CoV-1, has potential to infect the neurons and glial cells throughout the CNS. Now, this is a cartoon depicting the sites, areas in the brain where the AC2 is present. It's present in high density in the substantia nigra, olfactory bulb, middle temporal gyrus, in the motor cortex. And among the cells, it's present on the neurons, the microglia, astrocytes, and the oligodendrocytes. Now, how does the virus invade the nervous system? There are two routes of invasion. One is called the transsynaptic route. Where the virus binds to the terminals of the peripheral nerve and then retrograde along the nerve synapses, gain access to the CNS, and through the transsynaptic route, it will enter the CNS parenchyma. This is a cartoon showing the same. So now the virus binds to the terminals of the olfactory nerve, and through the transcribiform plate along the olfactory nerve, it goes along the nerve, and within the nerve, it enters the vesicle. At the synapse, it goes in for exocytosis, and the other end of the synapse, it goes for endocytosis, and using the fast axonal transport microtubules, it will reach the cell body. The second route of entry is using the blood-brain barrier, is by the hematogenic route. Here it can the virus can infect the vascular endothelium, and or the leukocyte which are already infected in the blood can cross the blood-brain barrier. So this is again a cartoon showing the virus within the blood vessel. It invades the vascular endothelium, then it goes on to enter the astrocytes, or the leukocytes which are already infected will transmigrate and involve the astrocytes which are present in the CNS parenchyma. Now already this in the present pandemic and in the previous SARS-CoV, this neuroinvasion has been documented in the autopsy studies and also in the experimental animals. In China and Japan, one patient each, the ribonucleic acid of the virus has been identified in the CSF. And also viral particles of the SARS-CoV has been identified in the brain of the infected patients. There are other serological markers also, which shows there is neuroinvasion, like the GFAP and the NFL, which are products of astrocytes, and the axon are increased in patients with this infection. Now, what are the neurological manifestations? Now, SARS-CoV has got SARS-CoV has high homology to SARS-CoV-1 and MERS, and appears to have the capacity to injure the central and the peripheral nervous system. There are two methods of involving the nervous system. One is a direct, causing neuroinvasion, and the other by hypoxia, coagulopathy, and the immune injury as a result of the infection. The most common neurological manifestations include headache, anosmia, and ageusia. The others include stroke, impairment of consciousness, seizures, and encephalopathy. Now, what is the pathophysiology of neural abnormalities in COVID? So first, what the virus does is binds to the angiotensin converting enzyme receptor. And once it binds to that, it gets internalized and enters the cell body. This will cause damage to the mitochondria and the lysosomes, and this will lead to increase in the reaction oxygen species, and this will lead to misfolding of the proteins. And by binding to AC2 also, it prevents the conversion of angiotensin 2 to angiotensin 1. And the resulting high levels of AT2, angiotensin 2, can cause pro-inflammatory markers, which can lead to vasoconstriction, vascular permeability, edema, injury to the cells in the lungs, brain, heart, kidneys, as well as the process involved in pro-apoptosis and aging. So what happens once it binds to AC2, this triggers a cytokine storm, which we have all heard about it many a times you get in this pandemic. So this is what is cytokine storm. It causes you get a marked elevation levels of interleukin 1, 6 and tumor necrosis factor. So what happens when these you get in the presence of these inflammatory markers, there's inflammation in multiple organs. And the cytokine storm also triggers the hypercoagulation cascades to cause you get small and large blood clots. And combined all these factors like the hyperactivation of inflammatory markers, the vascular injury, and the coagulation factors contributes to the ARDS, like acute respiratory distress syndrome, the renal failure, myocardial infarction, as well as multiple neurological conditions. This is a cartoon showing the binding of the virus to the AC receptor. Now, once it binds to the AC2 receptor, it gets internalized, and then it goes and affects the mitochondria. And this leads to, again, a lot of protein misfolding, aggregation of proteins, and leading to cell death. And the second step, and the second process is, there is an increase of angiotensin 2, which, as I told earlier, leads to increased inflammatory markers and leading to injury to the brain, heart, and multiple organs. Now, patients who get with COVID not only suffer these pathophysiological changes because of the COVID infection, they also get subject to lot of psychological stress. Now, sustained exposure to stress leads to high levels of cytokines in these patients. And this can contribute to, in addition to damage per se by the virus, the psychology stress can lead on to variety of neuropsychiatric and neurocognitive symptoms in the long term. Now, going on to the, what are the features you get, the patients will come with the neurological symptoms. The patients will come with when the patient has infection with COVID-19, with coronavirus 2. So some of the early neurological symptoms were anosmia and ageusia. And this is because of the infection of epithelial cells of the nasal and oral mucosa. And there is high density of AC2 receptors in the olfactory epithelial cells, nasopharynx, and oral mucosa. So binding to these receptors will inhibit the function of the sensory receptor cells that mediate olfaction and gustation. And there can be also, in addition, central mechanism, the involvement of the piriform cortex, etc. And it has been known the incidence of the reported incidence of anosmia and ageusia has varied from the Asian and the European countries. In China, it has been around 5%, in contrast to around 33 to 83% in three European studies. And this variation may be because of the polymorphism of the AC2 receptor. Now, cerebrovascular disease, like the strokes are common in the severe COVID infection, and those who suffer from stroke are usually those who have, in addition, hypertension, diabetes, and obesity. Most likely, in these patients, the hypercoagulable state leads on to the higher levels of inflammatory markers, such as C-reactive, ferritin, interleukin 6, TNF, and D-dimer. And it has been known that the type of stroke in these patients, that ischemic stroke, and only handful of them is because of the hemorrhage. The third common feature is that seizures and encephalopathy. Now we know that in ICU setting, when the patient leaves the ICU setting, patient in the ICU setting can develop a memory loss, or there can be slow processing speed, delirium, or even coma. But it has been seen that COVID patient, in addition to the other patients compared to other patients with these delirium or coma, they are having more incidence of delirium and coma. And this again seems to be immune mediated more than a direct viral encephalopathy. And this he get delirium and encephalopathy has been due to the injury to the blood-brain barrier. So once you get there's an injury to the blood-brain barrier, what happens is these toxins you get enter the brain parenchyma, especially in temporal lobe, where the blood-brain barrier is weaker. And this entry into the brain parenchyma leads to seizures and encephalopathy. And only get 2 cases have been reported where they get the nucleic acid by PCR has been demonstrated. The other involvement of the COVID-19 involves the cranial nerves, peripheral nerves, and the muscles, where the common GBS of the axonal type has been documented, and this is mainly because of the pathogenesis has been related to the molecular mimicry. And there can be vasculitis around the nerve. Also, there can be myositis. And cartoon showing how we get the vasculitis leading on to the hypercoagulate state you get within the vessels, leading on to clots, and leading to and which can further involve the multiple organs like stroke, a myocardial infarction. All those can happen because of the hypercoagulate state. And again showing a nerve, the nerve where you get the antibody against the myelinoaxon can lead to GBS. Now, if you see the whole picture of the neurological manifestation, a conceptual 3-stage has been put forward. That is in neurocovid stage 1, where the virus binds to the nasal passages and the tongue. The patient may only have just loss of smell and taste, and there may not be other features. In neurocovid stage 2, what happens is there can be involvement of the blood vessels. A hypercoagulable state in the blood vessels can lead to clots in the organs and lead to strokes or MI. Or the nerves involvement can lead to GBS or myositis. And the third stage, where the blood-brain barrier is involved, there can be leakage of the toxins into the brain parenchyma, leading to encephalopathy, delirium, and seizures. Now, what are the long-term effects of the COVID-19? Now, there have been documented neurocognitive and psychiatric conditions following the long-term effects. It has been told that since the neurons have got ACE2 and the virus binds to ACE2, they can enter the cells, and once inside the cell, they can cause protein misfolding. And the protein misfolding in a person who survives the COVID infection over long-term time, what happens is there goes aggregation, and theoretically it can lead to brain degeneration decades later. The other second process is that the cause of long-term effects of COVID-19 is because of the inflammation, the hypercoagulable state. Like the cytokine storm, already I told, can result in clots within the small or large vessels, leading on to injury to blood-brain barrier, and later leading to neuropsychiatric consequences. Now it has been told, like even ARDS, like acute respiratory syndrome, even in other conditions, when the patient survives this syndrome, they are left with cognitive impairment, which is a cognitive impairment. They do not come back to the baseline cognition, which is before the admission, and this cognitive impairment is modified by other factors during the state of admission. Now we know COVID-19 is mainly a respiratory distress syndrome, and here many people those with severe infection suffer with the ARDS, and when they recover, some of them who recover or many of them who recover can have cognitive impairment, which can have a lasting over many months. So in future, over the next maybe coming years, we may have to look for a wave of patient who present with depression, post-traumatic stress disorder, anxiety, insomnia, or psychosis, as well as cognitive impairment or decline. As this has been documented following Sars Cov1 infection, almost maybe around it was documented after about 31 to 51 months. There was about 1/3 patient had post-traumatic stress disorder and depression in 1/3, and other last 1/3 of OCD and panic disorders. Maybe similar instance we may also come across in future over the next 2 decades. And presently, there's a new syndrome called the long haul COVID or the long tail COVID. Like in health workers who are in the early part of the pandemic, who are more exposed to this virus, they even after recovering from the acute phase, many of them still complain of persistent symptoms more than 100 days. And this is called the long hauler, long tail. And this is similar to the myalgic encephalomyelitis or chronic fatigue syndrome that patients get reporting it usually after a viral infection as a trigger. Now, coming to the topic of more importance for all of us today will be how the COVID-19 is going to impact the ADRD diseases, ADRD, Alzheimer's diseases, and the related disorders. Now, patients with Alzheimer's disease may be at a higher risk of developing COVID-19, and there can be associated increased morbidity and mortality. Now, there are several factors why there's an increased risk of contracting COVID-19 in ADRD patients. They may be unable to understand, appreciate, or remember the recommendations regarding prevention of the Sars Cov1 infection, such as hand hygiene, covering the mouth, you can maintain social distance from others, or remaining at home. And some of them may not follow due to apathy or depression. Others, because of the behavior and psychological symptoms as a part of their illness, they may go in for wandering, which may undermine the effects. Then it has been known, like in COVID disease, like age and the comorbid medical conditions is the most important factor which has led to poor prognosis. Now we know that in Alzheimer's disease, the disease patients, their age is they're most of them are elderly and most are associated with comorbid medical conditions. And this has been illustrated in the situation in Italy, where a third of confirmed cases and approximately 9 of deaths had occurred in individuals 70 years of older. COVID-19 also has got impact on the diagnosis and the clinical management of ADRD. Now, once you get the number of patients with COVID-19 infections increase, most of the resources, both the human and the infrastructure, is diverted to the COVID-19, and there'll be a strain of healthcare system, and there'll be suspension of lot of elective and non-urgent care, care in the individuals with ADRD, like cataract surgery or you get orthopedic surgeries. All those may be delayed, and the visits you get of these patients to the hospital may be difficult because of the frail individuals. They can get more susceptible to the get infections, and we may have to change over to the virtual care you get for these patients with all the added limitations, where you get the neurological examination, physical examination, some of the cognitive tests may have maybe a little difficult rather than actually visit to the hospital. And regarding the medical management, most of these patients would have been a long-term drugs for their like the antidepressants or antipsychotics, and they may be stable with these drugs. Suddenly, because of the COVID, because of the lack of visits you get, or not able to get the supplies you get being delivered to them, there's a suspension in the drugs being delivered to them. They may have acute symptoms, new symptoms may occur, and change of drugs at this time may further deleterious to them. And the non-pharmacological management for these patients, which important, part of their management in general, will be difficult to implement because of the social and the physical contact which are restricted during this situation, during the present situation. And we know that, as I told, there's a lot of impact social responses. There'll be a lot of travel restrictions and home confinement. So, and one of the papers it has shown that the neuropsychiatric symptoms during this home confinement, like in France, it was shown that among the 38 patients who were evaluated, like 10 of them following home confinement for over 2 months, their neuropsychiatric symptoms worsen, and this worsening was more in those with the lower baseline cognitive level. Now, not only the patients affected, the caregivers and physicians may be affected, and this will further they may also go and have to have treatment or isolation, further impair the care of the ADR patients. And this during this time, normally the mental hygiene and all this which requires routine, certain activities may be suspended and also the stigma of isolation. All this further impacts the mental hygiene of ADR patients, and they may going for delirium during this time. And also, now we know that last 2 decades, there will be much focus on the research in the ADRD. But with the advent of COVID-19, much of the research has been suspended because more emergent and urgent situation has come up. Now, what we'd all like to know, does COVID-19 has any impact on the Alzheimer's disease risk? Now we know that all the primary dementias, the pathogenesis in this is based on certain conceptual models of retinopathies. Like those who have a risk factors, and in these patients, those who have risk factors, there's accumulation of different lesions, it can be different types of proteins, amyloid or tau or synuclein. Any of this can get accumulated. So once these proteins get accumulated, it goes in for neurodegeneration because of the loss of synapse, neuroinflammation, neurodeath, or glial reaction. And once there's a neurodegeneration, it can lead on to cognitive line. Now, the similar picture has been many medical hypothesis has been put forward in relation to COVID-19 and Alzheimer's disease. Like there is quite a few common symptoms, common scenarios for both the conditions. Like COVID-19, it has been shown like COVID-19, once it enters the cell, it causes injury. At that time, as an antimicrobial peptide, beta amyloid is secreted. Now we know that in Alzheimer's also around 15 to 20 years earlier itself, beta amyloid gets deposited, and as the virus persists, as I told earlier, can persist in the cells. So at that time, more amount of beta amyloid, there's an incessant production of beta amyloid, and this can aggregate and cause and may further lead on to the a picture of AD. The other one has a common similarity of the presence of ApoE allele both AD and they COVID. It has shown that presence of ApoE4 has got an increased susceptibility for viral infections. So also ApoE presence increases the incidence or risk factor for Alzheimer's disease. And ApoE also has been known to increase the damage to the blood-brain barrier, and both increase the damage of blood-brain barrier can lead to neuroinflammation, which can happen with COVID-19 infection. Similar neuroinflammation also is documented in the Alzheimer's disease. The other way it can happen is in relation to the ACE receptors, and also you get the microglial activation. Both ACE2 receptor involvement, their upregulation can sometimes lead to further damage, which has been and also the microglial activation also can cause further damage, which has been seen in the COVID-19 infection. And similar picture microglial activation has also been documented in Alzheimer's disease. So these are the some of the proposed mechanisms, the hypothesis which has been put forward for possible more incidence of Alzheimer's disease in future. So in short, I would like to end my talk saying that COVID-19 can impact patients with Alzheimer's disease in multiple ways. One is they have got more susceptible to the infection. At the same time, once they get infected, because of the age and comorbid, they have got to a very poor prognosis. And the other one is because of the confinement, the isolation, they're more prone for neuropsychiatric symptoms. And also there's lack of the daily care, but because of the health resources being diverted for COVID care. And also there's a decrease in the research in this direction, and there's a possibility of neurodegeneration, which in future, over the next 2 decades, we may have an idea as to whether it's only a hypothesis or a reality. Thank you.
Thank you, Dr. Bindu, for the informative presentation about how coronavirus affects nervous system. We have few questions from our audience. First question asked by Dr. Bindu John. Is there any methods to decrease the viral load in nasal and oral mucosa? I'll repeat the question once again. Is there any methods to decrease the viral load in mucosa and nasal and oral mucosa?
Hello? Thank you for the wonderful, thoughtful question. Definitely, we can decrease the viral load. Always, prevention is better than cure. And the most important is what we are following now, use the mask, which has been, been presently considered to be equivalent to mass vaccination. But once it has invaded the nasal mucosa, I don't think there is any method.
Thank you, madam. Next question asked by Reggie Verghese. Do we encourage prophylactic anticoagulant therapy for reducing the risk of stroke and other thrombolytic events in COVID-19 patients? If so, what is the treatment protocol regimen?
Yes, it's been already established in vogue treatment protocol for reducing the incidence of stroke in patients with COVID-19. Like when the patient goes in for the moderate symptoms, like their patient has already got a pneumonia or blood markers is showing D-dimer, all these are increased. That's inflammatory markers are high. The patients are given low molecular weight, heparin as a prophylactic this one. The treatment protocol can be OD dose is given for 7 days.
Thank you, ma'am. Next question asked by Dr. Bindu John. In contrast to other countries, it was reported in newspapers that the individuals affected in India with COVID-19 belongs to 21 to 40 years of age. What would be the reason?
I think it's very difficult to answer this question. Only in the long run, after further investigations, we'll be able to tell. Maybe the population in India is more of the middle and the younger age compared to the other Western countries where the population and the lifespan is higher. But exactly why the younger age group in India is more involved, I have no idea.
Okay, ma'am. Thank you. Once again, on behalf of everyone here today, I thank Dr. Bindu for taking the time from her busy schedule to talk to us about future implications of ADRD. Thank you, ma'am. With this, first session is over. Let's move on to the next session. It's my great privilege to introduce Dr. Kuruvilla Thomas, a well-known name in the field of mental health, who is the head of Department of Psychiatry of Lisie Hospital, Ernakulam. He is presently working as a chief psychiatrist in Kusumagiri Mental Health Center. He is an international fellow in American Psychiatric Association and co-chairperson of World Psychiatric Association section of Psychiatry, as well as the co-chairperson of Law and Ethics, and has about 30 years of experience in the field of psychiatry. Today, he will be sharing with us his expert opinion about management of ADRD. Sir, I am respectfully invite you to carry out the session.
Very good morning to all. I thank the organizers for giving me the opportunity to address August virtual audience. I understand that you had a very fruitful session yesterday discussing the different aspects and the problems which the caregivers face. Just now I listened to my colleague, Dr. Bindu, giving a very extensive review on COVID-2 virus, the neurophysiology, and a detailed discussion about how it might affect the people in the future. Now, with this in the background, I'll give a very short presentation on the management of ADRD in the context of COVID-19. As you know, in dementia, since the brain is affected, definitely you can expect that the person would have behavior problems. In 1999, Breitner et al. Did a study And in that study, the most prevalent symptoms were apathy, 27%, depression, 24%, and agitation, 24%. Apathy, as you know, is a symptom which is denoted by withdrawal. The patient will not show any interest at all. A lack of indifference. It's a sort of indifference. Now, 90% of these elderly dementia patients experience at least one symptom like a depression, a false belief like a delusion, hallucination, one of the 5 modalities, but more so in the visual, apathy, aggression, or a disinhibited behavior. Now, as Dr. Bindu mentioned, all these neuropsychiatric symptoms lead to more rapid cognitive and functional decline. And since it is a problem which is faced by the caregivers, that can lead to their distress and lead to a very earlier institutionalization or say hospitalization for these patients. And the problem is that all these depressed patients, they may maintain an adequate food intake. The apathy patient may lie on the bed for a very long time, resulting in decubity ulcer due to the ulceration at the point of the sacrum. And the patients who become physically aggressive, they may cause a problem for the caregiver to give the best of the care. Dr. Bindu has just been mentioning about the involvement of the immune system, and this is something which we read in the paper, in the news, every day they are advertising that to boost the immune system and thus to protect the person from the COVID-19 sequelae, the food, drinks and all those things. I don't know how far all those things are helpful to improve the immune status as such. But then, psychoneuroimmunology is a very, very important aspect. There is what is called as a cytokine hypothesis. When we have been just mentioning about the cytokine storm, the pro-inflammatory cytokines, interleukin 6, interleukin 12, the tumor necrosis factor. Now, these interleukins or the cytokines, that itself actually contributes to the onset of depression. So in that way, the depression that occurs as a sequelae of COVID-19 is not just due to the stress factor alone, but then there is a biological correlate for it. Now, these features may not be very typical as we see in a classical depression, but there could be a cognitive decline. Now, the caregiver might notice a change in what from what the person was before. That is, the person may lose interest in what used to be pleasurable, what we call as an anhedonia. There could be crying episodes, but not always. And many of these patients may have added psychotic symptoms like delusions and hallucinations. Now, psychosis, delusion is very common, and most of the time the delusion that we get in a dementia patient with a psychosis is a paranoid symptom, a suspicion that, and mostly it is a suspicion that the things are stolen. The difference of the paranoid delusion in a dementia from that of another psychotic disorder is that it is not a systematized one. What do you mean by systematized delusion? That is, if you ask, you are telling that somebody is harassing you. How do you say that? The person will be able to go on describing that. Yesterday I was there, and then I saw some light, and then I opened the door, and then I saw a person standing there. That is what is called a well-lit story. But a person with a dementia, with a cognitive decline, he will not be able to tell you a story like that. That is what we call as a non-systematized and a non-bizarre. What do you mean by a bizarre? In a patient with this paranoid schizophrenia, when there is not much of a cognitive decline, the patient would be telling about, something like a chip implanted in the brain, or, somebody taking away the thought from the brain or something like that. That's a bizarre. But such type of bizarre delusions, the dementia patient may not be having. The problem is that these patients, often the symptom that they insist is that most of these people, they say, they don't feel that they are at their home. They feel that they are in a different place. Probably they will be having the memory of their, of their childhood or something like that. So most of these people, they say that they want to go home. That is one problem, even the going away, the wandering, all these things is because people think that they are not in their home. And some of them may have the feeling that, their father or mother or the brother who has been dead for long, they see that they are there with them. And sometimes these people say that the son or the daughter-in-law are imposters, that they are not their original, but they are the duplicate person. I said that the hallucinations could be in any modality, but in a dementia patient, it is more in the visual modality, and it is mainly due to the cognitive dysfunction. Now, in your everyday practice, the three troublesome symptoms, I would say, in a dementia patient. Number one is sexual disinhibition. You know that there is a damage to the frontal lobes, the areas that would actually give a person the thought as to how to behave in a society, which is gone in a dementia patient. And that is a very, very troublesome problem for people who are giving care. I remember a daughter-in-law, she came to me and said that, doctor, there is some change in my father-in-law. Because of late he has been behaving very badly to me. I lived in my house only for, say, 25 years. I've been living in this house for 30 years, and I'm quite sure that never ever my father-in-law would behave like this. So there is some change. This is what an intelligent daughter-in-law would come and say. But then, for the others, it's a problem. There will be chaos in the family. The second problem is an impaired satiety sense. What is impaired satiety sense? You are feeling that you have taken the food. That satisfaction, it is there in the hypothalamus. Now, when the hypothalamus gets damaged, the person doesn't know, and the person goes on eating. Or say after half an hour, the person would say that I have not eaten anything, give me something. To the extent that I have had patients who have actually complained to the police, who have telephoned to the relatives, telling that nobody is giving me food. So that is again a problem which people face every day. And of course the paranoid symptoms I already mentioned. Now, Dippo already mentioned that, people who have dementia are at a high risk because, the usual things, I don't want to repeat it again. They are not able to follow whatever that the guidelines, all the guidelines they are not able to follow, and because of that they are always at a risk for this COVID-19 infection. And also, if a person has a basic psychiatric problem, that again is a problem that again increases the risk because he is not able to understand. A psychotic patient is not able to understand the need for wearing the mask or maintaining the social distance. This again, I think people have already mentioned, the apolipoprotein risk factor for dementia. That again actually increases the risk for the COVID-19 and all those things. I think I just pass it over. Now this study is from a hospital in Italy. In people living with the dementia, increased confusion is often the first symptom of any illness. That for that matter, see, a dementia patient, let it be any disease, like say myocardial infarction or a pneumonia or a urinary tract infection. The first stage is usually a confusion. They have a delirium or even a hyponatremia. So the caregiver actually should be watchful of a change in the behavior, in the sense that it may not be a frank, say depressive symptom or a psychotic symptom as such, but a sort of a confusion is usually the present feature. And with this particular study, they found that the delirium, as is again a confusional state, was there in 67.1%, hyperactive 50, hyperactive 17. we find that, it was actually more than the fever that they observed, or it was more than the cough symptom that they observed. So the initial symptom could be a confusional state, which or a change from what the person was before. This is something which the caregiver should be able to detect and inform the concerned person. Now, the non-pharmacological strategies is the first one that we'll have to give, the caregiver support and education. I'm not going into all those things. I'm quite sure that, in yesterday's talk and they would have really emphasized on all these things. But you should actually ascertain whether there is some physical symptom which is actually aggravating, like, pain, infection. All these things, might be affecting the person, and that could be resulting in this behavioral problems. So it is very important that the caregiver should assess whether he has any physical symptom which is causing a problem. Now, the non-pharmacological limitations, I think again, Bindu has already mentioned. We have discussed that already. So then comes the pharmacotherapy. Because all these things, when the person goes into a depressive state, a psychotic state, patient becomes aggressive, you may have to report to pharmacotherapy. But the first word on pharmacotherapy that I want to tell is avoid it as far as possible. Avoid it as far as possible. Because many studies have already shown that if you initiate pharmacotherapy, the lifespan decreases. So again, you go on emphasizing on the caregiver support, ascertain whether the person has any underlying other physical problem which is aggravating, which I already mentioned, and then treat that, a silent myocardial infarction, a silent pneumonia, or a silent urinary tract infection. So you avoid, what I mean by pharmacotherapy is the psychiatric pharmacotherapy. Avoid it as far as possible. And the problem is that, the thoughts, the person, if you are giving a pharmacotherapy, a psychopharmacotherapy, often, the side effects of the pharmacotherapy is the sedation, and that would result in a fall. Already the bones must be in a pretty bad shape due to the osteoporosis, which can lead to fracture. And you know that in an elderly person, especially in a dementia, a fracture could often be the beginning of the end. Now, another problem is that, most of these drugs that we give, it can cause a postural hypertension. That is, the person suddenly he gets up, and the dementia patients, they just suddenly get up, they just suddenly go to the toilet, and there could be a change in the blood pressure due to the drugs, which can again cause a fall. So the caregiver always, especially in a dementia patient, I think the caregiver need not be a trained nurse. Even the person at home should be taught how to take the blood pressure. What is postural hypertension? A systolic difference of more than 20 and a diastolic difference of more than 10 could be a postural hypertension from the lying and the sitting position. Because these drugs cause postural hypertension, again the problems of fall, fracture, everything is there. Then comes the anticholinergic side effects of most of these medications. So because of the anticholinergic side effects, the person may have dryness of mouth, constipation. One of the problems with the elderly is that they are really worried about their bowels. The bowel clearance is not there. Many of these drugs actually cause constipation. That constipation itself again causes confusion. So the drug which you are giving to alleviate a confusion, you give it, you produce a side effect that causes the problem. Or a prostatic hypertrophy in an elderly male, there could be a retention of urine. Or an anticholinergic side effect itself causes confusion. So that is a problem which the care should always keep in mind. Then you have the extrapyramidal symptoms. And then one of the extrapyramidal symptoms which is most troublesome is akathisia. What is akathisia? Akathisia means a feeling of restlessness. That is, a person when he sits, he feels like walking. When he walks, he feels like he feels like sitting and lying down. When he lies down, he again wants to walk. And this is what we see in an agitated patient. So often what happens is that the patient has an agitation, patient is walking around, take him to the doctor, you put him on a medicine, the medicine causes Psychothesia, the agitation increases. So it is really, and the caregiver would come back and say that, you know, the restlessness has increased. You think that it is the underlying disease has possibility, you pump in more medicine, the agitation again increases. So it's really very important for you to take the history. How was the agitation before the medicine? Has the agitation increased after the medicine? Could this medicine that we are giving, could it be responsible for this? These are all things which you should actually accept. Now, so we have to give medicine. Sometimes we give the antidepressants we have to give, some especially the ones which we are really generally we are using now are SSRIs and all. And now I'm just going in, I'm not going into the details of the drugs and all those things and such, or the dosage of that. But suppose you have a patient, now we are actually coming to the point that we are going to treat a COVID-19 patient who has an associated depression. Now, probably we would like to use an SSRI like a fluoxetine, paroxetine, fluoxetine, buprenorphine, or a basket full of agents out there. Now, for the COVID-19, the patient might be on, not that they do use it every day, but they might be on lopinavir or ritonavir. Now, the cytochrome P450 inhibitors is the mechanism by which the drugs are metabolized. So these drugs are, the SSRIs are also inhibitors, and the lopinavir and ritonavir are also inhibitors, and there could be a drug interaction. So what I'm right now telling you is about the drug interactions. Now the citalopram mirtazapine can cause QTc prolongation. Now you know that you give the hydroxychloroquine and the chloroquine, you would have read in the paper, that it causes prolongation, that all those things. Again, there could be a synergistic effect when you give it with citalopram or mirtazapine, which can prolong the QTc. Now the tricyclic antidepressants, again, it can cause many problems, arrhythmias like the torsade depot, that is a multifocal ventricular arrhythmia, ventricular fibrillation, and even death. Not that all these things occur every day, but then these are all possibilities which you should keep in mind. Again, as I mentioned, when you are giving antipsychotics, the haloperidol, quetiapine, all these groups again can prolong the QTc, can have an interaction with the hydroxychloroquine or the azithromycin which we are giving. Lopinavir, ritonavir, again, what I mentioned, again these things and the haloperidol and the antipsychotic group can have an interaction. So these things have to be kept in mind. The mood stabilizers, lithium generally doesn't cause any effect, but the person might be on NSAIDs, which can lead to toxicity. Valproate is again a mood stabilizer. The level of valproate is decreased with lopinavir, ritonavir. Lamotrigine level decreased with ritonavir. So there is a drug interaction between the drugs that you use for depression or psychosis and the drugs that you use for COVID-19. Now, sedatives and hypnotics. The higher doses of benzodiazepines, can cause a respiratory depression. Generally, the oral drugs do not, but in an elderly person, when the health is really very bad, you do not know, the person can go for a respiratory depression. Or again, the severity-related interaction with the antivirals can occur. So the best is to use a short-term, short-acting drug like lorazepam. That is the best suited one for a person if the patient requires a sedative. So what I mean to say is that pharmacotherapy is often essential, but then you should be really very, very careful and in giving it. I'm not going into the details, the usual drugs that we give in for dementia, like the anticoagulants, the tacrine, donepezil, rivastigmine, galantamine, and the NMDA receptor antagonist, memantine, and all those things, These things, they claim that it actually reduces the progression of the disease, that it improves the quality. Personally speaking, I don't know. I'm very skeptical about these drugs. Really, how far all these things are effective, we do not know. So with that, I think I will conclude my talk, just repeating what people have been telling always, there is no point in just prolonging the life, but then you should add life to years, that you should add quality to the years that you live. Thank you.
Thank you, Dr. Kurula. We are very grateful that you took the time out of your busy schedule to address this group. You gave a terrific presentation of valuable updates on management of ADRD. Really, it was very informative. You conveyed it to all very effectively. Here is few questions from audience. Dr. Usha Marat asks a question. Can we see dementia to be a sequelae of SARS, a CV infection, in future? I'll repeat the question once again. Can we see dementia to be a sequelae of SARS, a CV infection in future?
We do not know. We are yet to know about it. But then definitely we should expect it. That is what we are not really certain about it. But then it's a possibility. Yes, definitely.
Thank you, sir. Once again, on behalf of Lisie family and everyone here today, I thank Dr. Kurula Thomas. Thank you, sir.
Thank you.
Before beginning the session, I would like to remind you once again, the feedback form link will be given in the chat box towards the end of this session. Everybody should fill the details carefully without any mistake.
It gives me immense pleasure to invite the resource person for the next session, Mr. Blesson Thomas, Registered Nurse Manager, Fremantle Trust, UK. I am glad to say that he was our alumni. In addition to Registered Nurse Practitioner, he is also practicing as a nurse practitioner in UK. And moreover, I am very proud to announce that he was National Award finalist for the Best Dementia Care Manager twice in UK. And he is the apt person to deal with the communication problems, the digital revolution in ADRD. So over to you, Blesson.
Thank you. Am I audible?
Yes.
Thank you. Is my screen, can you see my screen?
No, no, Blessing. Yes.
Yeah, is it, oh, can you see now?
No.
No,
No,
okay,
no.
that's fine. Good morning, everybody. I greet everyone who's listening to me from the different parts of the globe, especially in India, at different time zones that we are in. My name is Blessin, and thank you, Manju ma'am, for the introduction. I'm extremely glad to be part of the series of this international webinar series that's been organized by Lisie College of Nursing, Lisie Hospital, as a part of the Alzheimer's Week. We have been hearing to different eminent speakers talk to us. The last 2 days, we heard somebody talk, 3 speakers talk to us yesterday, and I did attend yesterday's session, and it was very informative. And once again, it was very knowledgeable to listen from some very eminent speakers today as well. I greet Dr. Bindu as well as Dr. Kurmila Thomas, who spoke prior to me. On this outset, let me wholeheartedly greet and extend my appreciations and thanks to Professor and Principal of Lisie College of Nursing, Dr. Usha Marad, the organizing chairperson and my own teacher. It's such a privilege to be with you, ma'am, after so many years and to share this platform. I also greet Professor Manju George for the invitation, and I appreciate ma'am for all her hard work behind this, this webinar series. I also appreciate the organizing committee, and overall, let me say that it's a very nostalgic moment that I've got here before me, available to share some information that I have with you on this special week. Let me also greet the respected directors of Lisie Hospital for their fabulous support as well. As an alumni, as said, I'm always proud of Lisie Hospital and Lisie College of Nursing. I would say it's the best place that I have had in my career life. Today, even though I'm miles and miles away from Lisie College where I actually learned, I think so this is the day that I remembered that college a lot after I graduated from there. And I think so I feel that I'm in the college today where memories are, there's floodgates of memories that's opened up, and I just can't disconnect from that college today at all today. So it's such a fabulous feeling, and I thank the organizers for this opportunity. The topic that has been entrusted to me is on telecommunication in ARD. That is Alzheimer's diseases, related dementia. Several parts of this topic has been discussed in the last few sessions, and the outline of the topic that I'm going to talk today is, I'm going to talk about telecommunication and its need, challenges, top tips to take when you're communicating something over telecommunication devices, technological advances, telemedicine, and support for families and carers, and finally also talk about the future. Let's begin by talking about what communication is. It is no doubt that communication plays a very vital role in human life. It is not only helps to facilitate the process of sharing information and knowledge, it also helps people develop relationships with others. It is an integral part of the existence of human life. Can we think of a day that we have not communicated with somebody or we have not used telecommunication? In these days, it is very rare that somebody who doesn't know how to use a phone or doesn't use that in their day-to-day life. Imagine one day your phone is broken down. I think so you're completely lost, or you do not know, you feel insecure, not knowing what is going to happen. Somebody once said that we should learn to communicate well to make our lives better. So it's such a lot of importance on communication. But as we are focusing on dementia, I would say that Alzheimer's disease related dementia, for those patients, communication can be extremely difficult. As dementia progresses, it becomes harder for the person to tell others about themselves and what others are saying to them. So sometimes there might be issues where that resident or that patient cannot tell others what they are feeling, and they can't understand what is being said to them as well. So communication is critical for everyone. When we think about telecommunication, because that's where I'm going to focus today on, telecommunication is nothing but the transmission of information by technology, or communication through technology is called telecommunication, as simple as that. So transmission can be taking place over radio signals, optical signals, and other electromagnetic systems. With the advancement of the world, we see that communication is improving, and each day as we go, and each minute, I should say. Telecommunication has actually revolutionized the patient care completely. It has opened up a great variety of new possibilities for personal communication, information, and also for giving people a better quality of life. If you just think about what mobile phones have done in the care of elderly, because the elderly are the people who get dementia more frequently. If you look more compared to the other people, we understand that the importance of, or the benefits of using like a simple device like a mobile phone is like it helps with personal communication. Imagine in the past, around 20 years ago or more, we used to always use fixed phones. We used to pick up the phone and use the handler, and we used to say hello to people. But now phones are with us. You know, just like we carry a wallet around, we have got our phones with us as well. So it helps to get to anybody in a limited period of time. We see that with COVID, we have seen that a large number of people depending upon telecommunication, especially when people are in quarantine, self-isolation, COVID patients, and so on. We see a lot more people using FaceTime, WhatsApp, Skype, etc. And we have seen that the places that I work in, we have seen that lot of people now depending upon purely on a lot more on telecommunication. Security. People feel a sense of security. Many older people, you know, who have got restricted mobilities, who are confined to their homes for whatever reason, they have also been, you know, got that sense of security. Many times we have heard people say, I don't mind living on my own as long as I've got a phone that I can reach out to people. Social integration. We see that people who live in very remote areas are still able to connect to the other groups of people. And this has helped avoid discrimination of people who are living in disfavored regions of the world as well. So that is also very significantly noted. All this has helped in a patient living an autonomous life as well. So to access integrative services for the older people, more opportunities are being given to them. So they have got a better quality of life as well. Let me now move into saying about what are the things that we got to keep in mind when we actually communicating to somebody, using a telecommunication devices. Now, the first point that I would like to share is that before you speak, you know, what are the things that we got to keep in mind before you speak? Is it a good place to talk? Is the environment quiet? Is there good lighting? And are there no distractions? We got to make sure that all these are in place. Get the person's full attention before you start. There's no point in communicating if you can't get a person's attention. Next is position yourself where the person can see you clearly. This is especially when you're using any sort of video communications. So position yourself properly. Have an open body language. Be open and be relaxed. Have enough time. Make sure that enough time is given. Do not feel stressed or rushed, but calm down. Plan what you're doing. Plan what you're going to talk. Don't simply talk something, because to talk to a patient who has got Alzheimer's disease, you have to really plan what you're going to talk, especially using telecommunication devices. Understand if there is a particular time of the day when the person is more able to communicate. Sometimes they have got certain medications. We heard about the different impacts and the side effects of medications that the persons with Alzheimer's disease might take and has got on their life. So it's important that we analyze what time of the day and what kind of medications they take. Make sure that patients' needs are met, like they are not hungry, they are not in pain, they are not restless. So these kinds of things also have to be looked into prior to communication. And make sure that the most appropriate communication device is selected. You don't just pick up any communication device, but we always make sure the most appropriate device is being selected for a particular patient. How to speak? How do we speak? Number one, we speak clearly and calmly. Speak at a lower pace. Allow time between sentences. You know, when you allow sufficient time between sentences that you speak, you might feel a bit uncomfortable and you might find that there might not be a flow in the talk. But for a person who's suffering with dementia, it is very valuable that sufficient time is given so that they can understand the information that's been passed to them. Do not speak with a raised voice. There's no point in having a very loud voice. It'll get them frustrated. So please make sure that we speak not in a raised voice. Use short, simple sentences. Speak in a conversational way. Do not ask too many questions because they will feel as if they're being interrogated. So speak in a conversational way. Have a sense of humor. Sense of humor has to be properly used. If not used up properly, it might be classed as abused. So we have to make sure that a sense of humor can be used. It's a very good tool to communicate, but it has to be used appropriately. And finally, make sure that we include the person in the conversation. If you've got conversation taking place through a telecommunication device, make sure that we include the person in that conversation as well. What do we talk? And what do we say? We talk matters that is important to that particular person. Stick on to one idea at a time. Choice is good, but too many options might be confusing. If hard to understand, fragment the sentences. Rephrase rather than repeat. What that means is sometimes you can't understand anything, something that's being said by them. If you constantly ask them to repeat it, what's going to happen is they are going to become uncomfortable and they're going to become frustrated. But rather, you rephrase that question back to them, they will be able to better understand it and they might come to you. You might get them be more compliant to what you're asking. If person becomes tired, take a break. For a person who suffers with Alzheimer's disease or related dementia, they tend to become tired after talking for some time. So make sure that a communication is short and there is regular communication taking place. You want to communicate something big, make sure that it's been broken down into smaller pieces and it's been communicated in small intervals. Go with the flow, do not contradict. Sometimes contradicting can be leading to a situation where they become extremely, they would not cope. Listen carefully, offer reassurance. Make sure that you give plenty of time for them to respond.
Excuse me, sir.
Yes.
You are not visible now.
Yeah, it's okay.
Okay, yes, visible.
And look for the body language as well. So as they speak, make sure that you look into somebody's body language as well. There are some extremely big challenges that we have faced during this communication, these COVID seasons because of communication. We have had patients who had been extremely frustrated because of the use of PPE. One of my patients who has been with me for long years, one day came and told me like this, Blessing, I like the previous hospital I was in. People looked after me so well. They had a smile on their faces. But I don't like the current place I am in because people do not smile. They have all their faces covered. I don't know what is happening. And this particular person has got advanced dementia and she can talk. And she was telling me that. So I went to her and said, I called her by her name and I said, do you understand one thing? You are in the same place. You are not in a different place. You are in the same place. I pulled my mask down at a safe distance and I told her, this is Blessing. This is so-and-so. And she was thinking that she's in a completely new place. And she was telling us about the medications she's trying to take, about the way how her care has been delivered to us. She says that she likes tea, not coffee. And I said to her, do you know something? I know all that about you. You don't have to tell me. But she was thinking that she is in a completely new place because of the impact of us wearing the mask and the full PPE. So you can see that how much profound effects that has on patients who have got dementia. Sometimes we think that our patients can understand what is being happening around them, what things are going on. Sometimes it doesn't. Some of them do understand, but especially for patients who have got dementia, it is a huge, huge challenge. We have seen that people becoming anxious, they can't see their loved ones anymore because of social isolation. They're confined to their rooms because of quarantine, and things like this have made situations so tough. and they become extremely frustrated. What happens is that they are not able to, because they can't see their family members anymore, they become frustrated and they start having got more behavioral problems. We heard about people having increased number of falls. They're becoming more restless. They become agitated. They do not want to comply with medication management. They are not sleeping well at night. And we see all this happening during this COVID season. But what we have done in these situations is that we have now depended more onto telecommunications. And we have looked into how can we use communication devices more to enable that these people have got, or the patients have with dementia have got a fulfilled life. For that, we have used some of the technological advances that we have got. We use mobile phones more, and we have got some specific apps that we can use, dementia-friendly apps for these people. So we download these apps and make sure these apps are being provided. Example, MindMate, dementia agencies, dementia emergencies, Luminosity, and some creative apps also depending upon what kind of dementia stages they are. We include like Let's Create, flower gardens, virtual aquariums, trip to the zoos. All these different kinds of apps are available, which is specific to dementia, and these are being also provided. And we can see that there's better interactions and they're getting a fulfilled life. We're using more of FaceTime, WhatsApp, Skype, so that families can meet and talk to the loved ones as well. What we see is that sometimes patients with dementia do not understand. You walk around them with an iPad or you walk around them with a laptop, you try to show them their loved ones trying to talk to them. They look onto it, they try to touch it, and they can't get any tangible feeling from it. And then they disconnect from it and try to walk away. So we have been trying to communicate back with families. Very recently, we have started families coming back again and the bystanders coming back. And what happened is that what we tend to see more happening is we see people requesting, saying that, can I come and touch my husband, please? They said that I had a very touching request from one of the wives of one of my residents or patients very recently. She wrote to me and said that, Blessing, can I come and touch my husband's wife? He smiles at the care staff who look after him. He smiles at the nurses there, but he doesn't even recognize me anymore. He doesn't understand who he is. And you see that a lot of families bringing photo albums in and saying that this is me, this is Marion, your wife, this is so and so. They're trying to say, don't you remember your child? Look, this is Jack, this is Jim. They're trying to reintroduce relationships, and they're using a lot more of technology to make sure that these things are being done. We are using, with technological advancements, we are using Alexa, a virtual assistant, where we use technology. It's a virtual assistant that's used through technology, like to play music, to provide information, deliver news, sports scores, tell you what the weather is like, control your smartphones, and also help to place Amazon orders. So it's lovely to see how we are trying to use this as well to engage our patients as well. So that they are confined to their rooms, they've got an Alexa. They just need to talk to Alexa, say that, Alexa, what's the weather today? And Alexa will tell you the weather is so and so. So those people who have got dementia, even though they have got dementia, doesn't mean they don't have abilities. Depending on the stage they are, we have seen that we have been able to use these as well. We have used a mobile text telephony in the sense, when we talk to a mobile phone, it types up the text message for us. You don't have to literally sit there and type. So they will sit there and they'll talk to their mobile phones, and it types as a message, and the message gets sent to their loving daughter. They just need to say that, can this message be sent to my daughter? And they talk to that phone and that message gets sent. We have seen that mobile phones have been used to access internet. In the past, we used to have a huge gadget in the homes of people to access internet and Wi-Fi. Now we just need a phone, and that's a hotspot for people to access internet at home and all that. We have also seen that those families or those patients who are living out in the community or living on their own, they're using GPS through mobile phones, in the sense that they can live on their own. They are under quarantine. They are higher susceptible for COVID. So they might be living under isolation or whatever. So they just got these phones with this GPS activated, so that the family members know exactly when they might leave the house, or if anything else happens, if there's an accidental emergency at home. So like I am lost scenarios might happen. So in these circumstances, they can quickly pick up the phone or come quickly rushing, or they can alert the police and say that my father or my mother has left the house, and they are in at-risk situations. So we see a lot of that taking place as well. So definitely technology has hugely helped us in the care of patients, especially during this COVID season. Sometimes there are some myths that people have about COVID. I've seen that one of the common myths that some people have is about older people reject technology. We hear this a lot. Just think around 10 years ago, how many of the older people were using ATM cards? Very recently, I came to India, and I was just wondering the age of the people I could see lining up in the banks and lining in front of ATM counters, just waiting to use the ATM cards. They know about debit cards. They know about credit cards. They know how to withdraw money that's come to their accounts. And I see that technology has helped people to use facilities more. You know, we know that young people are very enthusiastic about technology. But at the same time, when you train up the older people, they can also use technology. We cannot say that older people just reject technology. We cannot say it. It's a pure myth. Very recently, during this COVID season, I had a patient of mine who was 95 years old. She set up a Facebook account and she sent me a Facebook request. And I just wondered, I looked at her and said, that's lovely to see you set up a Facebook account. And she is now posting pictures on it of how lovely she feels and how well she is looked after. And it's lovely to see how she's engaging. So just to say that it's just a pure myth that we have saying that older people reject technology. The other common myth that we got around us is that technological devices are too difficult to be used by the older people. No, we come to say that, oh, technology, we know that so-and-so is of so age, they cannot use the technological devices. How do we expect them to handle that kind of technological devices? We tend to say that a lot. But let me tell you, there are so many youngsters who are struggling to even use technological devices. But let me tell you, over these past COVID seasons, I have seen several elderly people using technology as never as before. There is a design philosophy called design for all. What this design philosophy says that if you're designing something to be used, you have to make sure that's going to be used by everybody. They have got this, for the marketing to be best done, they always look into saying that if I'm going to develop a smartphone, is the smartphone easy for everybody to use? So this kind of technology, this kind of design philosophy is out there. It's called design for all. And now it is just enormously enhancing its usability. So making sure that this is made dementia friendly and made sure that this can be accessible. So sometimes people in different parts of India might ask, say that, listen, these are difficult technologies for us to access. What is something that we can access? Something very simple. You know, you can have dementia friendly telephones. You go to Amazon, you can buy from internet, dementia friendly phones. You just have got bigger dialers. You can put photographs of your loved ones there. And when you press the photograph on that particular dial, it automatically rings the son. It automatically rings the daughter. So just enhancing the ability of people during this time of COVID as well. We heard how much importance is that we have to quarantine. We have to make sure that the infections are not spread. And we heard about the vulnerability of the aged. We know all this in mind. But at the same time, we have to equip. And we have also find out different technology that's out there that we can use to enhance our quality care. We have got another app that we use a lot. It's called Familygram. What Familygram does is families go on holidays, families at home. They can't send letters because of the possibility of COVID coming through letters and everything. So what we do is that we wipe everything coming through. Families do not want to go to the post offices to post something. So they download this app called Familygram and they just put their photograph in and a message. It gets automatically emailed to the person you want. And then it comes like a postcard in the design of a postcard and you can deliver it to the people. So we have been using that as well. So if you look overall, I think so it's a high time that we have to depend upon technology. We have to look on technology. What can we implement? In the environment that I am, I consult patients, I see patients on a day-to-day basis. I have to make differential diagnosis. I have to talk to our GPs. GPs mean general practitioners, just like doctors back home. And we have to come with plans and we have to prescribe medicines and all that. So in the past, doctors used to regularly come to see our patients. Now doctors do not come that regularly. What they do is that they all use something called as telemedicine. What telemedicine is that? It's a laptop thing that is kept there where it's accessible to healthcare providers 24/7. You've got doctors, clinicians, consultants available. There is a virtual room that you can meet You can have the family, you can have the patient, you can have the nurse, you can have the doctor in one virtual room together and discuss about somebody's care. So telemedicine has developed. So that is how we consult our patients. We even do verifications of death on telemedicine. So if there is somebody who passes away at home, in the past we had to have a doctor to come to verify somebody as dead. So, but now technology is advanced and we do not have to have the doctor come home. So what we do is that, just use telecommunication devices to verify somebody's death. So we are using much more of telecommunication in our days compared to what we used in the past. So the most important thing is that we get over the myths, we identify what are the resources that we can use and use this appropriately. In India, there is Alzheimer's Related Disorder Society of India, and they are based in around 24 cities across India. They have got a national helpline, and people can pick up the phone and ring them for advices. I think so. We heard from the third speaker yesterday who was talking in detail about the support you can get from them. There are care lines, that phone number lines that is available, care staff or support staff or caregivers who can also ring and ask for advices. It's a very challenging time for all of us. Countries in the Europe here are going through possibly a second wave. It's again thinking of how many deaths are we expecting? How many cases are we expecting? In United Kingdom, we are expecting around 50,000 cases by the mid-October. That is how the statistics show. We have got around 4,000 to 5,000 newly diagnosed COVID cases per day. So they are implementing harsher rules, more lockdown restrictions in place. But the only way ahead is that, yes, we have to provide quality care for patients. We have to make sure that everybody is safe. The safety of the patients we look after, at the same time, our own safety as well. So it's paramount that we have to use technology and embrace technology. Some people openly reject technology. And I say that they are old school. What we have to do is that, how do we use technology to our best of our abilities? Let me finally just conclude my talk today by just saying about how, what are the advances that we have seen using telecommunication. Some of the things that we have seen that people with dementia have got a satisfied life. They are more compliant. They love. Sometimes we say that patients with dementia do not have abilities to access technology and everything. We have got patients with dementia who can operate iPads, handle mobile phones, even ring a manager like me and talk to me what their concerns are. So it doesn't mean that people with dementia do not have the abilities to share. People with dementia has got the ability to share. Let's not say dementia is a disease, put it to one side. Let's not label people, but look into what these persons can do. What can we give them? What can we do to make their lives better? So as we spread the awareness of Alzheimer's disease in our society, I think so it's high time that we appreciate what these people are capable of. Give them that support. Encourage that independence and to do the best so that they have an improved quality life. Thank you for patiently listening to me, and thank you for this opportunity.
Thank you, Mr. Blessing Thomas. Really, your presentation was very fascinating and very informative. There is some questions from our audience.
Yeah.
Question from Alina. Were you able to contact patients in remote areas? I'll repeat the questions once again. Were you able to contact patients in remote areas?
When I answer that question, I need to say that currently in the United Kingdom, we have got good connectivity, we have good network facilities. Hence, it's not been difficult to connect to people here. We have got patients in different areas, but technology is advanced, very advanced in this country. So hence, it has not been difficult to reach out to those people. But I understand that from a point that when you talk from India, yes, there is challenges of accessibility in remote areas. And there's one more biggest challenge is about economy as well. So how many of our people who live in remote areas can access telephones or mobile phones or all that kind of technological devices? So it might be a challenge in India, but India's technology and digital India is going ahead. I think so. It is fast paced, but in this country, in United Kingdom, it has not been a big effect. We have been able to reach out to people.
Thank you, sir. You shared your knowledge and vast experience very nicely. Once again, on behalf of Lisie family and everyone here today, I thank Mr. Blessing Thomas.
You're welcome. Thank you.
Father Jerry Nalier, Assistant Director, Lisie Institutions, who constantly inspires and motivates us, who has been with us throughout the entire journey. Father, I invite you to deliver valedictory address. Father will join soon. I would like to remind you once again, the feedback form of the link will be given in the chat box. You can fill the details carefully without any mistake. Once again, I would like to remind you, the feedback form will be given in the chat box.
Hello.
Father will join soon.
So I'm already here.
Over to you, Father.
Yeah, is it time for me to start?
Yes, I invite you to deliver valedictory address.
Okay, okay. Thank you, thank you, thank you. I hope Blessing is still there. I hope he's
Yes.
still there. Yeah. I think you all had a very good session. Session where you must have got a lot of practical knowledge, practical perspectives as well. And Blessing, I would say that he's one of our family members. And what I heard from the faculty members is that he's an award winner for 3 times for the care giving he is giving to the dementia patients, the elderly people there. We are very proud of you.
Thank you, Father.
Yes, Blessing, yeah. Most welcome. And I think Dr. Usha is here, and all the faculty members and many people from around the world are participating in this session. I say hello to everyone who are participating in this session from Lisie Hospital. September is a month where we think about Alzheimer's, we think about the dementia, and we speak a lot about all these things and the people who suffer from this, people who live with this, the people who give care to these patients. So we we speak about a lot. We speak a lot about these in the month of September, and 21st is the Alzheimer's Day. And this year, the theme of Alzheimer's Day is let us talk about dementia. I think until recently, there was not much discussion about Alzheimer's or dementia. But with the advances in neurosciences, now people know what is the reasons behind this, what happens biologically, socially, and how things evolve. So people have started speaking about dementia, about Alzheimer's, and about all related issues more than ever before. And we all have the feeling that, maybe until recently, we all thought that this is something distant to us, not that close to us, this issue. But today we know that this is an issue which is very close to our lives. Sometimes in our own families, we have, people who struggle with dementia, people who struggle with Alzheimer's, we have to care them. So it is not a distant reality anymore. It is there with us. It is there in our families, in our society. So, so there is no point in postponing to discuss about these things. That is why this theme is very relevant. I would say, let us talk about dementia. We have to talk about dementia loudly, clearly. We have to think about different perspectives of the issue. So I really appreciate at this point of time Dr. Usha and her team for bringing up this very relevant topic to the platform, and to bring eminent personalities, people who have got hands-on experiences in this field, to bring different perspectives of this issue. These issues faced by the patients, by the caregivers, by the family members. I hope we, over these 2 years' time, we had ample opportunities to discuss different perspectives of these issues faced by the patients, by the caregivers, by the family members. And it is, I would say, at this COVID time, it has got a added importance, relevance, because as we already heard in different sessions, COVID-19 in a biological sense and also in a social sense has contributed to impact to the COVID patients and to the dementia, the people who suffer from dementia and Alzheimer's, and the caregivers. It has contributed in a sense. It has impacted in a negative sense somehow, because the virus itself, COVID virus itself, has got some implications to aggravate this issue that we already discussed that issue. And in a social point of view as well, during this COVID times, we are going through we are socially, there are a lot of changes happening. Perspectives are changing. In a sense, we can say that there is a positive impact. We can say the family members, young people are staying more at their homes. They can spend more time caring their parents, their grandparents and all. So in that sense, we can say it may be, helping in a way positively the people who suffer from dementia or Alzheimer's. But at the same time, it is not that easy for the people when they stay back home, especially when they are not used to do so. When they stay home, sometimes not going for the work, spending more time at home, that can impact in a negative sense as well. The frustration from the loss of job, or frustration sometimes being held held in the home itself, isolated. All these things can make negative impacts as well in the way we respond, in the way we react to the people, in the relationships it can affect. So we are still not in a position to say whether it is impacting in the social sense positively or negatively. But the good thing is human beings always have a way out. You know, we adapt to the situations, we evolve according to the situations. So I'm sure, you know, even notwithstanding all the implications of COVID, we will evolve, we will find solutions to the problems. And that is what exactly happened during these 2 days, over these 2 days time. I to find new perspectives, to new solutions, to the patients who suffer this dementia or Alzheimer's, and you know, to give some sort of solutions to the caregivers, to the family members who deal with these issues. So in that way, I'm sure these sessions, with the help of eminent and knowledgeable persons around the world, from around the world, has helped a lot all the people who participated in this. And we are proud of us, Lisie family. We are proud of bringing this program at this you know, relevant time, this relevant topic to many people who are now sitting around the world. Once again, I congratulate Lisie College of Nursing, the team under the able leadership of Dr. Usha, for bringing up this program, and all the eminent personalities who contributed in different sessions to enlighten all the participants who participated in these different sessions. Thank you and all the very best. Stay safe wherever you are. We are praying for you. We are praying for you all. I hope we will catch up again in another program which is this much relevant again. Thank you. Thanks again. Thank you all. And all the very best.
Father. Thank you, Father. Thank you very much for your inspiring words. Now I invite Professor Manju George, HOD, Mental Health Nursing, to deliver vote of thanks.
So I convey warm wishes from Lisie family to all of you. Hope that all of you enjoyed each sessions of the webinar, and thus we were able to talk about dementia. As per this year's slogan, let us talk about dementia. And I am sure that you will talk your family, your friends about dementia these days. So if that has happened, we are happy that this webinar came to a success. I hope so. And at this juncture, let me, on behalf of Lisie family, let me express a word of gratitude to all of you. First of all, I thank God Almighty who abundantly helped us in each step from the very beginning, without whom we could not have offered this webinar to you. Then I express my heartfelt gratitude to Reverend Father Paul Karaden, Director, Lisie Medical and Educational Institution, who was there to motivate us, guide us, and through his inspiring words during the inaugural address, he gave full spirit to the delegates. Thank you, Father. Next, I extend my sincere thanks to Reverend Father Jerry Naliat, Assistant Director, Lisie Medical and Educational Institution, for his constant encouragement and valuable words during this valedictory address. Thank you, Father. Now I extend my sincere thanks to our beloved principal, Professor Dr. Usha Marat, who was there with us, giving us valuable suggestions and guidance throughout each step of this webinar. And she was being the organizing chairperson of this webinar, and through her keynote address, he gave an overview of this webinar. And thank you, ma'am. And I also express my sincere thanks to our Vice Principal, Professor Risa Peter, for her constant encouragement throughout this session. And now I extend my sincere thanks to Mr. Bobby Paul, Assistant Manager, Lisie Medical and Educational Institution, who was there with us from the beginning, irrespective of his busy schedule, to make this webinar a success. Thank you, sir. And I take this opportunity to thank the speakers of this webinar. Yesterday we had Dr. Achila, Dr. Bindu, Mrs. Ashley, and today also we had Dr. Bindu B, Dr. Kurubula Thomas, and Mr. Blesson, who these experts make this webinar a grand success. I extend my heartfelt thanks to all of you. And I utilize this opportunity to thank the IT department of Lisie Hospital, Mr. Jijo and his team, who make this webinar a grand success by keeping social distancing during this COVID-19 pandemic. And I also express my gratitude to Mr. Venu, Communication Officer, who helped us to mold this webinar into this. Now I extend my heartfelt thanks to my colleagues in the mental health department, Ms. Minnie Matthew, Gidu K, Divya Matai, who all are there with us throughout this webinar. And I utilize this opportunity to thank the other medical institutions run by Lisie family, that is Lisie College of Pharmacy, Lisie College of Allied Health Sciences, teaching and non-teaching staff of this institution helped us directly or indirectly to mold this webinar. And I thank teaching and non-teaching staff of Lisie College of Nursing who were there constantly encouraging and supporting us throughout this webinar. Last but not the least, I extend my sincere thanks to all delegates. Without you, we can't run this webinar in this manner. Thank you all. Once again, I thank you. Thank you all once again. And I hope that all of you had a take-home message that let us talk about dementia. Thanks. Thank you all.
With this, we came to the end of the session. Thank you all. Have a nice day.